Hello, I'd like to welcome all of you who are joining us today for our Accountable Care Learning Collaborative webinar. This is Mark McClellan on behalf of the I'd like to welcome all of you and thank you for your participation, for all your continuing efforts around healthcare reform. We've got a pretty packed webinar today focusing on opportunities to leverage medical home approaches within ACOs. And I'm going to get to that in just a couple of minutes. I've got two excellent presenters with extensive experience in this area. Before I do that, though, just a few quick announcements related to the webinar and the ACLC. For those of you who have been with us before, you know that the best way to tune in is via Zoom. You can join the Zoom webinar on your computer or phone. If you're only able to connect by phone, don't worry. We are going to make the slide deck available after the call along with the recording, just like we always do. We are going to preserve some time in the last part of the webinar for questions and comments from all of you, but you don't need to wait till the end to let us know if you've got a question or comment. If you're on the Zoom application, you can submit them using the question module at any time. And again, we really encourage you to do that. This is a great opportunity to get some feedback from people who have been directly involved in integrating primary care transformation and medical homes into the accountable care organization framework. So for today, just want to start with a few updates on the ACLC upcoming activities, and I'm going to quickly introduce our guest presenters, Dr. Paul Grundy and Robert Fortini, and turn over the bulk of the time to them to go through their presentations. And again, we want to hear from you with any questions or comments, and we have time for that discussion towards the end of our hour together today. And just a few notes about upcoming ACLC events. As seems to be the case almost daily these days around healthcare reform, new developments and uncertainty about where many important aspects of coverage involving Medicaid, individual markets, and other areas are heading. We are not focusing on an update on those policy developments, those specific policy developments today. Keep in mind and that we will be sending you regular updates as we have been doing about new developments, and we are planning a longer time on an upcoming webinar to take stock of where we are and where we're headed with those healthcare coverage reform issues. I just would remind you all again that the reason that, a big reason these coverage issues are so hard is that healthcare costs are so high, and that's where the ACLC has generated and reflects a broad range of support for really taking steps to transform care. As we've mentioned on previous webinars, we have good reason to think that this momentum is going to continue, maybe shaped in a few refined and different directions, but clear and increasingly pressing needs to take steps like the ones that we're going to be discussing on the webinar today. With that in mind, we've got some other upcoming activities planned. A webinar on August 9th focusing on high-risk patients. We're going to have more details on that coming soon, so keep an eye out for that. The work group calls will be taking place in August as usual, and look for calendar invites on those in the next couple of weeks. And then really want to encourage all of you to plan to join us for the ACLC member meeting in Washington, D.C. on October 4th. We'll have more details on that coming soon. Some of you I know are also planning to attend the NACOs meeting, which is going to be in conjunction with ours. In fact, we'll be doing some joint activities together, so look for more information on that too. Certainly plenty of reasons to pay attention to some of the developments in Washington, and I think a lot that we'll be able to discuss and work on together at the upcoming ACLC member meeting, including some of the work on pathways for developing competencies that many of you have been engaged in, as well as some important guest speakers and other new developments. So we're looking forward to seeing you all in Washington in October. But for right now, I'm very much looking forward to hearing from our presenters on these steps for primary care transformation as part of implementing ACOs effectively. I'm going to introduce both of our speakers now. They've got a combined presentation that they're going to go through in the next half hour or so. And again, very pleased to have them with us today. Dr. Paul Grundy is a longtime friend and colleague who's currently the Chief Medical Officer and Global Director of Healthcare Transformation for IBM Healthcare and Life Science Industry Practice. Paul is very much engaged in the IBM transformation initiatives, which, as many of you, I'm sure, know, focus on using data and integrating evidence in new ways. But Paul has also been very much involved from the beginning in the use of medical homes and primary care innovations to support a more comprehensive and population-focused approach to efficient and high-value healthcare. He's the founding president of the Patient-Centered Primary Care Collaborative and has served as its president for a decade, a group that we've collaborated with extensively in the past around advancing primary care, and again, very much fitting into this overall theme of comprehensive care reform. Robert Fortini is a pediatric nurse practitioner and is the Chief Clinical Officer for Secours Medical Group in Richmond, Virginia. There at Secours, he is involved in leading the clinical transformation efforts, including implementation of an effective and advanced primary care medical home delivery model, as well as in other system leadership issues for Secours. So he has some very practical, extensive hands-on experience, not just in clinical care delivery, but in bringing this focus to some major changes in a major healthcare system. So looking forward to hearing from both of you. And Paul, I think you're going to be up first.
Thank you very much, Mark, and thank you all of you for for the leadership in the Learning Collaborative. It's really important. So I'm going to share my screen with you. Can everybody see that okay?
Not sure we've got it pulled up yet, and I know this works since we just tested it.
Yeah, we just tried it, didn't we?
Okay, there we go. I think we just need to get your slides up.
Yeah. Is that better now?
Yeah, that's great. And I think if you go into full screen mode, we'll be all set to go.
Yeah. Fantastic.
There you
Thank
go.
you. So about a little over a decade ago, I was part of our HR team at IBM, the folks designing our wellness, occupational medicine, and benefits for our company. And one of my big bosses almost died of a drug-drug interaction. And I got called into his office to sort of ask the question about what it was as buyers of care we were providing to our employees of value. And we started off by doing a survey and asking our employees what they really wanted in the care that they received. And the response back in what's called a JAM was they wanted access to a real healer in their lives. They wanted relationship-based care. They wanted much better communication. They certainly wanted better access, and they wanted better engagement. And what we found was only 26% of our employees could access a primary care doctor after hours if they had one. And what we also found was that a significant number of our employees didn't have a primary care provider. We began asking the question, what is fundamental? What is foundational for a delivery system that's going to be accountable? Where in the delivery system do we need to start to repair all that? And the paper that I read at the time was by a pediatrician from Hawaii, Cal Sia, who talked about the medical home coming out of pediatric literature. And what he was referring to was, if you're going to have data about your patient, that data has a home. It's not a home for the patient. It's not a home, for the doctor. It's a home for the data, so that everybody's singing off the same sheet of music. And then the next question was, where in the delivery system should accountability occur to manage that data? And what made sense from my 2 decades of working in Denmark and other parts of the world was for that fundamental foundational element to be at the level of primary care, based in a team of folks that supported that patient around managing them. And so we reached out to the House of Primary Care back those years ago, and we said to organize primary care in the United States, so general pediatrics, general internal medicine, family medicine, we would like a covenant change. We would like you to proactively manage our population instead of just having your office open to see our patient at 9 in the morning. And Doug Henley, the head of the AFP, and John Tucker, the head of the ACP, both of them said, bless your heart, this is exactly what we've been saying we should do. So the conversation really became, how do we move primary care into being the system integrator, into being the comprehensivist rather than doing small things? And so we asked organized primary care to give us a set of principles. This slide is the principles they gave us. They're immensely powerful. They're immensely powerful because they belong to organized primary care, and there's a commitment to delivering those principles in a concept. We then reached out to all of the healthcare plans. So by this time we had 47 of the Fortune 100 in the same room, agreeing that we wanted this. So a pretty significant book of business, right? I mean, the federal government, the OPM, was probably the largest employer in the room at that time, and they were, a big book of business. IBM, GE, anyway, almost half of the Fortune 100. And we asked the healthcare plans to gather in Washington and to agree to support the concept of doing some pilots around this concept of managing a population proactively with data. And interestingly enough, they all agreed that we should be doing this, but they also agreed that we needed to hold their feet to the fire, otherwise they would ride in the wake of the next guy. And so when one of the largest ones they all agreed to do multiple pilots, at least 3. They agreed to do it in 3 locations, and they agreed to collaborate together and use the principles and work with NCQA to develop some standards. So when one of the biggest of the plans backed out of that arrangement, I took them to the New York Times woodshed, and by 11 o'clock that morning, 14 of us of the Fortune 47 had canceled our contracts for that year, because that was the agreed on holding their feet to the fire. This is the initial data from those first early pilots. It's a no-brainer when you begin to proactively manage a population with data, and you do it right, you begin to see less need for butts and beds, you begin to see less inappropriate emergency use, et cetera. So, this was the early data that we saw. One of these early large pilots, and again, the autos were very involved with us, with Blue Cross Blue Shield in this, started then, and we have 7 years of data by September 2016. And by the way, we just talk about this quite a bit in the outcomes report that just came out on the Hill from the PCCC website. But what we're seeing, with 7 years of data, is that it continues to, show improvement. It continues to be successful. And this is pretty significant in that it's almost 4,500 or over 4,500 primary care physicians. So a very large pilot or rollout. Just this year, the Veterans Administration, which has been a real champion of this, so they've got about 10 million lives in this, began doing a deep dive on what is it within that model that delivers the most quality indicators. And you can see on this slide that the coordination of care, which you're going to hear a lot about from Secours, access to care, continuity of care, communication, all really important, but this gives you some indicators of what's really working within that system. So if you're going to change the way practices practice, if you're going to ask them to stop already opening their door at 9 and being ready to answer questions, but proactively manage the population whether they come in or not, then you're going to need to change the way you pay them. So practice transformation, the second element of this is payment transformation. And we've now had, quite a few years of experience, and many of you on the call have probably seen it as well, in terms of payment transformation. And the simple concept we're beginning to see emerge is that you need multiple dials. If you have one dial and it's fee for service, you're going to get too much service. If you're one dial, it's capitation, you'll get too little service. But what is it that you put in place to do that? Some examples of that were really successful. In Tulsa, Oklahoma, which was the first place that this particular element happened, and now it's in 7 others, we began paying the specialists to answer the emails from the primary care docs. And we began, for the first time, what happens is that dialogue becomes accountable because payment is being exchanged. You see a huge shift in the referral pattern, and the pediatric rheumatologist in Tulsa, there was only one, who had a waiting list of 8 months, went down to 2 weeks. All of a sudden, they're working at a higher level of their license. So all of the healthcare plans, CMS, Medicaid, all agreed, to make this little change in payment, and that, really demonstrated some satisfaction. In Grand Junction, we began paying for satisfaction level, but defined, right? I.e., access, after hours access, i.e., you get paid more if you answer your email in a certain period of time. Specific elements of what the patients want were being reimbursed at a higher rate. In my experience in 20 years in Denmark, that's a significant part of the payment, i.e., how well you give your patients access, how well you give them after hours access, all becomes a mechanism for how you pay. There are 3 factors that are driving this, and it's just so clear in the debates you're hearing on the Hill now that the cost element of this is the big concern. So this slide is the best way to look at how delivery systems add value. So this is 15 years of life lived from age 40 on. What country does the best at that and what price? And the United States is dead last of any developed economy. But if you look out here in the state where you guys are housed in Utah, you look pretty close in Utah to what exists in some of the best of the Western in this particular measurement. So there's huge variation, and companies like mine are looking at those kinds of indicators as to where they're going to put their jobs. And I think that's the first and the biggest driver of this. The second is data. For the first time, we're going to have data. Data is going to do for our minds what imaging and x-rays done for our vision. And thank God we're moving out of the information age into the age of intelligence, because the information age has not supported us like other industries in getting at the kind of data, because it's a gazillion times more complicated to launch a rocket to manage a diabetic than it is to launch a rocket to the moon. It's just the order of magnitude is really hard. So we began looking at data foundations, and then what do you need to be accountable with that data? You need the information to understand what's happening with your population. You need to then take that over to the ability to manage a case. You need to then take that up to how the system performs, and then lastly and finally, what's your risk, what's your cost? So, companies like mine have been putting together these kinds of tools with acquisitions of Fitel, Explorers, Truven, to begin to get at how you can be accountable with a data foundation that works. So the third thing that's driving this is that, my kids who are in their 30s have never seen a teller in the bank, they never will. For the first time, we are not trapped with the automobile being the last major advance in healthcare, in communication. I think well over 80% of encounters in the Kaiser system are now asynchronous. I know in my experience in Norway and Denmark, many aspects of communication are asynchronous. What's an asynchronous communication? Well, going back 15 years, in the Danish context, when you push your pill through the aluminum foil, the system at least knows you've dispensed the pill. And so you begin to get much more clarity. I mean, you've all seen the devices where you can monitor asthma, but simply a text message in one of the pilots we did in New York increased medication management adherence and compliance by 12% with a little twerp on the phone that was a reminder. So as we move into this new world, the model of care, the model that I grew up in, the Flexner model, where the doctor was the data storage device, the doctor was the master builder, is rapidly moving into the world you're going to hear about in a minute. That's already in place with Secours, where the patient's at the center of this. The patient's data is available to a team of folks that are going to manage your patient. And by the way, the clinician, the healer in somebody's life, the physician, the nurse practitioner, there's two things they should do with their time. That's difficult diagnostic dilemmas and relationships. I can tell you that medication management is much better done by a pharmacist, that behavioralists are probably better at behavioral issues. I mean, there's many folks that you can put on that team to really support that primary care home. So the model that we're moving into is going to be data-driven. It's going to be every person has a plan. It's going to be team-based, and we're going to be managing a population down to an individual level. And the amount of information that we're going to have about the transparency that's going on with that individual is increasingly phenomenal, including genetic information, et cetera. So this is the agreed-on movement. We're moving away from our patients make an appointment to see me to the patients are part of our community. We're going to proactively manage them. We're going to do it with standardized guidelines. We're going to measure the quality. We're going to use a team of prepared professionals. So from the standpoint of the patient, it's really about superb access to care. It's really about patient engagement. It's really about clinical information systems registry. It's really about understanding what's going on with the patient, whether you see them or not. It's care that's coordinated. It's CUME-based, profound change in communication, and use of mobile. So one of the pilots that I like to brag about a lot, and I'm really proud of, is the one in Vermont. IBM happened to have been the largest employer in Vermont at the time we started this. We worked closely with Governor Douglas, and a wonderful guy named Craig Jones led this effort. And what happened there is we all agreed to put 2 cents out of every sick care dollar into a role of a community care team. And so there's 11 communities in Vermont, and each of those communities has a not-for-profit community care team sitting in that community. So my newly diagnosed diabetic in St. Johnsbury, Vermont, where I went to visit, you know, they're introduced to the community care team. The community care team introduces them to the diabetic hiking club that meets on weekends, introduces them to the nutritionist in the grocery store. You know, the seniors caring for seniors, Senior Association agreed to support kids with special needs. And I thought that was going to be great for the kids, but what it turned out to be great for was the seniors. It really gave them a sense of purpose. And so you see the Senior Association now really engaged in maintaining for a much longer period of time seniors that are frailer than them at home, you know, really supporting them, helping them with chores, etc. And you really have a sense of community engagement there. And you know, I'm so proud to say that we have seen a 60% reduction in the complication rate of our diabetics, 60% less blindness, 60% less amputations. You know, when you begin to think about managing a population with data proactively in primary care, and you wrap a team around them that's actually going to do something to support that. And with that, I can turn it over to you, Robert, to tell us how it looks like on the ground. Thank you very much.
Thank you, Dr. Grundy. Great segue. If we can share the screen here, I can launch my slides. But just as an overview, my intention is to share with you some real practical applications of that care team redesign and the different roles, and workflows. And just give me a moment here to work through the technology, and we can begin. So, are you seeing my slide deck?
Yes, we are.
Wonderful, wonderful. Thanks for the feedback there. So I'm going to start out with a little general description of advanced patient-centered medical home. As Paul alluded to, PCMH 2.0. You know, we're at a time in our evolution now, a maturation, where some of those very basic primary principles, with the use of, you know, analytics tools and better information systems, you know, we've grown. So first, a little bit about Secours. Our employed medical group in Virginia is approximately 700 physicians at about 185 practice locations from Blackstone to the to Virginia Beach, the Atlantic Ocean. We're about 60% primary care, 40% specialty. And again, that was a strategic plan to increase the number of primary care practitioners available for meeting the needs of an aging community workforce. So advanced patient-centered medical home this is our formula. You know, 7 years ago, we were on paper. So we moved into an electronic medical record. We used that opportunity to leverage practice redesign. So there was better definition of workflows and communication within the practice. Clinical standardization to reduce variability from practice to practice. You know, for example, we have 185 locations. We use the same biomedical equipment across the spectrum. So an A1C measured in Blackstone is identical in the device, the analyte, the competencies, and the quality control as an A1C measured in Virginia Beach. And then, of course, we layered care coordination, and we'll talk a little bit about the role development of what we refer to as our nurse navigators. This is our payment pyramid, a little bit less sophisticated than the dials that Paul illustrated, but contains all of them for sure. Of course, leveraging people, technology, and processes to build upon available fee-for-service mechanisms to help fund the startup. That's critical, and I'll talk a little bit about that because, you know, we're just not completely there yet with value-based payment, and we're certainly heading into a situation where the ability to accept risk in all of our contracts, commercial or otherwise, is going to be tantamount success. So it takes a village. These are the fundamental care team elements. And again, to build upon what Dr. Grundy said, the provider might be the quarterback of the team, but the rest of the team is responsible for all that blocking and tackling and catching passes and running, and all of that team is focused on the patient, and all have to access to the same set of information and data entry. So we'll talk a little bit about each of these roles. I'm going to just briefly run through them right now. I'm going to spend more time on what we expect when we onboard a provider, whether it's a nurse practitioner, a physician's assistant, a midwife, or certainly physicians. The role of the nurse navigator and what that looks like, what our performance expectations are there. We have a team of pharmacists. You know, what is Western medicine all about if not about drugs? So why not have the subject matter expert assume a role in managing drug utilization? Oh, and by the way, PharmDs are capable of practicing with a certain degree of autonomy, and they can bill for certain things, and certainly with Medicare, medication therapy management, annual wellness visits. They have prescriptive authority in the Commonwealth of Virginia. They certainly serve as resources to our clinicians in the practice. And that's key because anyone who's out there in a commercial contract knows that generic drug utilization is a big thing. And it's also a big thing to our employers, who are paying for different medications. So having somebody who understands medication adherence and the best pathway and for terms of generic utilization is just part of the ROI, return on investment, associated with deploying pharmacists. Using diabetes educators and registered dietitians, I mean, we are what we eat. Medication therapy, medical nutrition therapy is critical to chronic disease management. I could prescribe all the diuretics I want for a patient at heart failure. If they go home and eat a box of macaroni and cheese and a bucket of fried chicken, it's all for naught. So again, trying to change that behavior is the obstacle in front of us. Very close integration with our home health team, not just our skilled nursing component, but our social work team. We also have a home-based primary care program where we have physicians and nurse practitioners who do home visits, and we have a palliative home-based program, so the highest risk patients who may be homebound, frail and elderly, are able to receive regular care from a practitioner in their home. I really personally foresee this as a tremendous area of need and growth, especially with an age-in-place movement, in an aging population. And then, of course, integrating behavioral health into the milieu. It's critical. I mean, if you can layer cognitive therapy with medical therapy, you exponentially improve the outcomes. So being able to deliver both while the patient is the captive audience is where that's aimed at. And there are many in America that do it very, very well, but there's still plenty of room for growth and improvement at integrating behavioral health. So let me talk a little bit about where we start with onboarding our physicians. We're very clear in our contracts to lay out specific performance expectations, and I'll share with you some of those. We recognize that while we establish those guardrails for physicians, we want them to succeed. So we're going to give them a tool bag of different tools in order to ensure their success. We also want to grow leaders. And so we have a very well articulated physician leadership program. And I shouldn't just limit it to the word physician, it's provider. We open it up to our nurse practitioners and PAs as well. Our job is to grow leaders and empower our clinicians. And then, of course, those first two elements help with a third, the idea of quality promotion, those guardrails, but also reducing burnout, again, by giving them the tools that they need to succeed in a consistent way. So here's some of the specifics in the contract. We define in our contracts the necessary for meaningful use of electronic medical record. We realize that data capture, entry, and sharing it among the team is critically important. And so our expectation is that all of our clinicians will document and use, to the best of their ability and to certain performance standards, electronic medical records. We have been very successful. I'm proud to say that in Secours, amongst our nearly 700 clinicians, we have done meaningful use attestation for 99% of them. And that's something to crow about. Of course, it positions us very nicely for performance on the macro as well. We do regular patient satisfaction surveys, and our expectations is that our clinicians and their office staff will meet those satisfaction standards. We certainly have quality standards. We're in several ACO-like contracts as well as an MSSP, where we have to report regularly on performance. There is a financial reality to all of this, so we have set a budget. So there are certain visit volumes that have to be met in this milieu. And then we have standards around access to care. It's not just a 9 to 5 operation that closes for lunch. It's got to be longer, more than that. And so we pay our physicians around those metrics, around those specifications. We have a base salary. We have a productivity bonus that speaks to that visit volume specification, but we also have a significant quality incentive bonus that's paid out annually. And this is just an illustration of 12 of those quality measures that our primary care clinicians are expected to meet. I know the words are a little tiny here on the screen, but if you could just read 11 and 12. So number 11 says the percentage of providers attributed patients aged 65 and older who have had an advanced care plan discussion documented in their medical record during an encounter within the measurement year. And the expectation is that 10% or greater of patients will have an advanced directive, age 65 and older. There's also an access measure, number 12. The provider opens their schedule for patient appointment slots outside of normal business hours, and the threshold there is greater than 120 appointment slots in a fiscal year. Again, access for our patients is paramount to success, and it equates, it washes out on all those other measures, being able to manage gaps in care, patient satisfaction and engagement, and so on and so forth. So here's some of the results. I mean, we've had very good results. Paul alluded to herding cats. Well, he himself has told me many times, and you saw the bag of cat food on the couch in his slide, the way you herd cats is you move the food. So that's essentially what this quality incentive is performing here. So look at this. This is advanced care planning by PCP. Once we started the incentive program, we went up exponentially. I mean, you could see this is a year-old data, but it has continued to climb. Most of our primary care providers have not just met the 10% threshold, but significantly beat it. Leadership development, I alluded to, is a mix of classroom experience. It's a year-long program. There's about 6 different sessions that are held. There's a number of different self-development modules that they're expected to complete. And then we hire experience wherever we can, and we have a mentoring program. So a new physician who is interested in leadership development is paired with someone who has great experience and can answer questions and support them as necessary. Okay, I'm going to move over to another member of the team now, our nursing case managers. And we have several different types, both registered nurse and LPN, both embedded in the practices, and we have probably 50 different locations where we have an embedded nurse navigator in the practice. That co-location is really, I think, far more effective in not only coordinating care, but communication amongst the care team. We have an extensive orientation and training program for whatever level of navigator is engaged. Ongoing training is bi-weekly and usually encompasses not just some type of workflow rehearsal, but also some type of clinical education, like pharmacokinetics, for example. We'll have our PharmDs come in and teach our navigators about drug-drug interactions or whatever. And then finally, our professional practice advancement program. So much in the way of our primary care quality incentive program, we, let me see if I can get to the professional practice advancement. Here it is. We have 4 clinical levels. Our nurses, both LPNs and RNs, by achieving certain credentials, can qualify for each of those 4 levels, and there is a salary increase for each of those levels. So it's, of course, based on evidence-based practice. We found that it not only improves our job satisfaction by giving the clinical ladder, but also is impacting our turnover rates, which everyone knows about nursing turnover rates these days in America. So here's the Navigator model, and you can see all the things I talked about and what we expect them to do, but the expectations specifically are on this page, and we literally built this since their annual performance evaluations. If you remember that payment pyramid, I talked about reimbursable care, because we still very much live in a fee-for-service world. So our RN nurse navigators are expected to be delivering these reimbursable modules. They certainly can do much of the heavy lifting associated with an annual wellness visit, the full risk assessment, the depression screening, the health risk assessments, the med reconciliation piece, even some of the care planning. But chronic care management codes are a billable event. And our expectation is that for those patients, Medicare patients that are, have a chronic disease, we will identify them and get them into case management and bill the chronic care management codes. Patient assessment forms. Many of our Medicare Advantage programs require extensive and onerous documentation in order to meet the criteria. So an RN with proper training can do a lot of the scrubbing in a medical record necessary to identify supportive documentation to justify a more sophisticated code diagnosis. And then finally, transitions of care codes, the within 7 days or 14 days of discharge for patients with a recent hospitalization. And I'm sure many out there are utilizing that, but it not only is there a financial reward for doing that telephonic outreach within 48 hours of discharge and bringing them in for a visit, but there's a substantial reduction in readmissions, which as a value-based payment modifier is critical to our health system as well. Oh, and by the way, quality of life for our patients. So we expect our clinicians to continue their professional practice development. We support them and pay for their certifications, whether it's in their specific area of specialty or it's case management in general. And of course, we have the clinical ladder program that rewards them at different pay rates. And then finally, the navigators play a huge role in advanced care planning, and all have a caseload of high-risk patients that are identified with the data analytics tools that we deploy. And we do actively and utilize in a robust fashion several of the IBM suite of tools to do that. Medical phone team, and I'm going to check my time here. I got another few minutes. This is the team that goes into our practices to prep them for our NCQA application process. And so I could probably spend all day on this slide, but I won't. Suffice it to say that we're trying to reduce variation, and we improve competencies of staff, make sure that we've got the right members of the team doing the right parts of the management of patient care when they show up. And we use those tools. We certainly huddle at the start of the day and identify gaps in cares or specific patient needs for follow-up. We use rooming protocols in a standardized way for standard wellness visits as well as chronic disease management. We have a very, very defined workflow for how we manage normal and abnormal results and follow up with our patients. We believe strongly in point of care testing. Why not get the A1C on the 91st day when you have the patient right in the room in front of you? The science these days has tremendous accuracy, and I'll be happy to share with anyone a literature research we've recently done to illustrate that fact for our own clinicians. We do medication refill by protocol, so patients are seen, labs are measured, generic drugs are utilized first, and the burnout and workload on our clinicians is mitigated. And then, of course, we believe very much in utilizing the patient portal for all of the above. And so part of our workflow on rooming is aimed at making sure patients know how to use it, are enlisted, are navigating comfortably, and are engaged. I'd just like to spend a few minutes on back office. And just like a great restaurant relies on not just its wait staff, but its kitchen staff to provide a gratifying experience and a wonderful meal. The analogy that Dr. Atul Gawande has used in one of his articles is absolutely the case here. What happens behind the scenes is almost as critical, if not in many cases more critical, than what happens in front of the scene. So here's just some of the support services clinically that occur behind the scenes, of course, using our analytics tools and reporting tools as aggressively and as robust a fashion as possible is critical. Biomedical equipment, I talked about the potential for variation there. We use all the same EKG devices. We use all the same point-of-care testing equipment. Our competencies for all are the same. Our quality control measures are all the same for each. So we have a team of people that literally is engaged at managing literally thousands of different devices across 185 locations. Central scanning, I'll talk about in just a minute. Big success there. Improving our ability to use our electronic medical records, giving our clinicians specific support for optimization and handling build requests. Our professional advisory committees play a big role in identifying outliers and people who need specific support. Managing our referrals. The medical group writes 20,000 referrals a month and to specialty care. And that's for primary care. We literally write 20,000 referrals. Reconciling that, tracking it, making sure a patient comes in is a hallmark of a medical home. And it's not just enough to write the referral, hand it to the patient, and expect the patient to do it on their own. So we have a big process in place with referral management. The SCR database maintenance, this is when you as a clinician are writing the referral order and you can't find the specialist. So managing that, or the fax number is wrong, or the address is wrong, or the specialty and how they're listed. They're listed under urology instead of urogynecology, or making sure that that database is maintained and updated regularly is critical for provider satisfaction as well as patient satisfaction. And then a well-articulated super user program where we have an individual at each location who's responsible for making sure the downtime backup devices are working, making sure that the downtime box is staffed to serve as a conduit for the latest information and communication about enhancements and optimization. So these are all critical steps that go to support practice functioning. So look at the scope I'm talking about here, central scanning. We have 130 practices that we support from a central location. That's 10,000 pieces of paper a day that come into a single location and with almost 99% accuracy get filed in the right file instead of just being dumped into a general media folder, so that the provider at the time of the next patient visit has to scroll through chronologically maybe hundreds of different documents before they can find it. No, we have a quality control mechanism in place to make sure that that cardiology referral gets filed into the cardiology folder. And we do those 10,000 scans a day with about a 72-hour turnaround time. So it's a pretty big provider satisfier. I spoke about referral management, but it's a critical factor certainly for medical home recognition or certification. It's also a big factor at meaningful use. A summary of care needs to be sent for greater than 10% of your patients. That's one of the meaningful use measures. And of course, will be one of the MIPS measures for all of us, moving down that macro path. So I'll stop there and pass it back to our organizers. I'm willing to take any questions that come in. Thank you.
Robert and Paul, thank you both very much for your presentations. We do have a little bit of time for questions and comments now, so if you haven't done it already, I'd encourage you to use that question box on the Zoom webinar link. In terms of some of the questions that have come in, though, I want to get to those in a second, but Robert, I thought I'd start by asking you first, since the repeal and replacement of the Affordable Care Act, Medicaid reform are in the news. From the standpoint of your organization, at Secours, how have these big coverage reform debates and controversies affected your efforts on this path towards transformed person-centered care?
It hasn't impacted it at all. It's the right thing to do. The most underutilized resource in healthcare is the patient. So building on that concept of a trust relationship is critical, and I think all of these things are contributing to that. I will say that despite Obamacare reform efforts, MACRA hasn't changed. MACRA has tremendous bipartisan support. And so, to participate in MACRA, you need to have many of these things are foundational to success, especially with track 2, where there's risk mitigation as a necessary factor. So I think we are very well in Secours positioned for success, certainly in MIPS initially, but then over to MACRA as well. As I said, we're in an MSSP, so we check the clinical transformation box. We've 99% attestation and meaningful use, so we check that box. Our MSSP ACO measure set, we're at the 90th percentile in performance nationally, so we check that box as well. And I think our utilization dollars will prove to check another box once we get into that.
All right. Well, thanks. I do want to get back to some of those payment reforms and how this whole strategy fits in with that. But we did get some questions related to the new kinds of skills and tools that you all emphasize was absolutely integral to the success of teams in this model. And maybe a question first for Paul. You noted in your presentation that data are key. And that this is really about centering around the data in support of the patient's overall care pathway and experience. Can you say a little bit more about what new training, skills, capabilities physicians need in order to succeed in these models, or are these kinds of responsibilities going to be owned by other practice staff, or is there a new type of individual who would be at the core of integrating and managing these key data?
Yes, I can. I think the key to thinking about this in terms of the role and the skills you need is that your brain is no longer going to be the data storage repository. It's a pretty flawed repository anyway, but at the point of care, increasingly you're going to have available to you much more robust answers, much greater ability to understand and clarify what's going on with your patient. And so, what we're talking about, I happen to sit on the board of the ACGME, and I'm on a faculty at UCSF, and what we're talking about is really a transformation of medical education towards much more an engineering process, i.e., instead of learning how to store information in your head, learning how to process, how to do thought processing, how to do problem solving, much more like an engineer.
Yeah, and Robert, you also emphasized the development, an active effort at Secours to develop some of these new kinds of skills, which I don't think many physicians or nurses or other health professionals are necessarily getting in their prior education, emphasizing the development of these skills. You talked about leadership development programs for physicians. Are those, how do you find the physicians to participate in those? Do they self-select? Do you screen? How many and how deep is the development training needed to lead in these new care models?
So they can self-select, but we also, of course, do an annual talent review and identify those candidates that we believe have the skill set and would benefit the most. So it's both. I will just tell you this as well. You know, the cowboy versus pit crew mentality is something that is changing, and you know, most often our clinicians are realizing that they can't do this all alone. They need to rely on the skills of others. When I first started here 7, 8 years ago, we introduced the concept of nurse navigators. Most clinicians didn't know what to do with them. But if I were to take one of those nurse navigators away now, or one of our PharmDs away, I'd have a riot on my hands, because they have become so dependent upon them to do all of the patient contact and you know, coordination that they just don't have the time to do. And that's it in a nutshell.
And in terms of the nurse navigators and other, I mean, there are a lot of, in your description of the care teams, a lot of clinicians who are not physicians. Do you all have your own training development program for the nursing staff who are now, you know, these indispensable parts of the care team, or pharmacists, or is that an area where you've been able to rely on kind of outside training programs more?
No, we've developed it for the lion's share on our own. I'm fortunate to have some very skilled educators on staff. Of course, we beg, borrow, and stole wherever possible from professional practice organizations and others in the field, site visits and, you know, learning sessions. But our orientation program and the ongoing training and education program were done internally.
Okay, great. We have had some requests from our listeners about whether there are ways that they can contact both of you regarding the skills development capabilities that you've described, and maybe a link to some resources. So we'll try to follow up with you right after the webinar to make sure that people who are interested can in fact follow up. There are a few more questions. I'm not sure we're going to have time to get to all of them, but some of them, just kind of looking through, have a theme related to tying back into payment. So Paul, you mentioned in your remarks that new payment models are needed for these new care models. Robert, you went through how Secours is compensating professionals internally to try to get alignment with better alignment with the goals of the organization, and just fee-for-service alone. It seems like you still have a significant fee-for-service component in that payment mechanism. Can you all talk a little bit about, from the external perspective, so from the standpoint of, say, Secours as an organization, or another entity that's, wants to become, is aiming to become a successful ACO, how much do you need to move to risk-based or more population-based payments, as opposed to trying to accomplish these steps within the as you pointed out, still pretty common fee-for-service framework? That's for either of you, I think.
Well, this is Paul. I mean, I think that in the existing fee-for-service world, I think that there are opportunities both in CMS, Medicare, Medicaid payments, and also most of the healthcare plans now have dials in place that are non-completely fee-for-service only. Boy, if I was a delivery system, I would look at those really closely, and I would try to maximize those. getting at tools that proactively manage a population like FITEL that Bon Secours uses, where you go out and you identify a population of patients that need a service, provide that service, and get an ROI on that while you're in a fee-for-service world. But those same tools can be applied, once you're in a more capitated or risk-based world as well. I think doing both of those would be really important. So look at places, and then finally, there's one place in the delivery system that every hospital is in the same boat that I'm in, and that's their own employees, right? So their own employees, they're 100% at risk for. Many successful systems, including Bon Secours, began really focusing on identifying payment change in their delivery system with their own employees because it was their own money.
Robert, any final thoughts?
No, I just say ditto to that.
Okay, great. So it's good ideas on getting started. This is obviously a big and challenging transformation, but we appreciate all of your insights in how to get from where we've been to where we need to be. And this will remind our listeners that ACLC is going to continue to provide some additional resources on that pathway and on how to put together all of these steps effectively, much as Bon Secours has done and as Paul has highlighted. So I want to thank both of you again for your presentations. Just a reminder to our participants on the webinar today, if you have any questions for us, you know how to reach us, members at accountablecarelc.org. We will work with Robert and Paul to make sure we get you some contact information for following up with them or some of the resources that they mentioned. And we look forward to continuing to work with all of you on this very important journey towards much higher value transformed healthcare. Thank you all again for joining us today, and we look forward to our next opportunity to work together. Take care.